Hello, everyone. Welcome to the interview for Global Voices section of the Heart Rhythm Online Open Access Journal. I am Dr. Uma Srivatsa, Professor of Medicine and Director of Arrhythmia Services at UC Davis, California. This interview today is one in the series featuring authors from our special issue published on December 16th, 2022. The special issue features original research and topical reviews representing the practice of electrophysiology and arrhythmia care around the world, with the emphasis on EP work being done in the developing world and amongst disadvantaged populations. To raise the awareness of the challenges faced by the physicians and researchers who lack needed resources, opportunities for improvement, advancement, collaboration with the global EP community. I'm here today with Dr. Jeff Healey, who will interview Dr. Dennis Lau and the first author of the manuscript, Bradley Pitman. Dr. Jeff Healey is Cardiology Division Director and Yusuf Chair in Cardiology, as well as the electrophysiologist in Hamilton, Ontario, Canada. With him is Dr. Dennis Lau, Faculty of Health and Medical Sciences from University of Adelaide, Australia. And Dr. Brad Pitman is a PhD student in cardiac physiology. And the topic in discussion today is their publication, Prevalence and Risk Factors for Atrial Fibrillation in a Semi-Rural, Sub-Saharan African Population, the Heart of Ethiopia, focus on atrial fibrillation study. Take it away, Jeff.
Thank you, Uma. And first of all, congratulations, Brad and Dennis, on a very nice paper. You've covered off two very important areas, that being atrial fibrillation and the global face of atrial fibrillation, in this case in Africa, and then the very timely area of atrial fibrillation screening. So a lot of interest, I think, we'll have with this paper based on your work from a center in Ethiopia. So maybe we'll just start for the person tuning in who might not have read the whole paper yet. Could you summarize in a few minutes what exactly you did, how the study was conducted, and what your main findings were for this?
Sure, thanks, Dr. Healey. So the study that we looked at, as you said, was a atrial fibrillation screening study that was performed in Ethiopia. We recruited 3,000 participants from a local community of a regional area south of the capital of Addis Ababa. At this center, we established a screening site just outside of a hospital campus where participants were asked to provide a tracing using the CardioMobile AliveCore device. This single lead tracing then provided a diagnosis of atrial fibrillation based on the automated algorithm. And we then performed a 12-lead ECG for participants that returned this result. And where possible, we also offered the opportunity for echocardiogram and then also follow up within the hospital medical facility for those returning a positive result of atrial fibrillation. From the 3,000 participants, there were 13 who returned a positive result of atrial fibrillation. And of those, we provided a breakdown of the risk factor profile for those participants. We also required blood pressure samples, height and weight for calculation of body mass index. And then a few of those patients were able to then have echocardiograms to look at their structural disease. We were surprised at the number of atrial fibrillation that we were able to detect, given the expected high prevalence of atrial fibrillation in a community that's generally high with rheumatic heart disease. Our cohort included all participants over the age of 18, and we had a number of participants in the younger age bracket, of which we only detected 4 patients under 40 who had atrial fibrillation. And we saw that the atrial fibrillation prevalence rose with increasing age. So Certainly the findings of our study are impactful for the knowledge of atrial fibrillation in the sub-Saharan African region. But as you said, Dr. Healey, it's also quite interesting for the utility of digital devices for atrial fibrillation screening in this modern age.
Yeah, no, it's very interesting. I also think you did find a lot of atrial fibrillation considering your setting and your population, right? On one hand, you used a relatively insensitive tool, that being a single time point handheld ECG for 30 seconds, compared to something like an implantable loop, that's, only a very small window. And you enrolled very young patients, many patients in their 30s and 40s. So, all things in the North American example might have predicted an extremely low pickup of atrial fibrillation. One has to, perhaps look at studies like Vital AF, where the incremental yield was very low with such a strategy. However, you raised two excellent points. First of all, you have a large background prevalence of rheumatic heart disease, which tends to tip the AF incident curve towards younger people. And, you're working in a healthcare system where perhaps there isn't as much background testing with things like Holters and ECGs and frequent physician visits. And so, you ended up with a very important result with a lot of atrial fibrillation being found, which I found quite impressive. Now, to maybe give the reader or the viewer a little bit better idea of perspective, so who were these 3,000 people? How many were they staff? Were they relatives of patients? Were there outpatients? Who precisely were these people, and how does that help us place your findings in context?
Right. The subjects who attended were all people who passed through the screening area that we set up, which is nearby to the emergency room of this regional hospital. There were a fair bit of word of mouth advertising from the younger group of people, because there is a nearby university. Hence, we had a lot of younger participants included. We didn't really collect the purpose of their visit to the hospital to be able to tell you the percentage, but there were a proportion of staff members, family members who brought someone who is ill to the ER. Were also invited to participate, and there were some who just heard about the screening and they came to the hospital for that.
Nice. So, of course, that last population raises a question, right? With any of these opportunistic, exercises and screening, you may have some bias towards, people with symptoms, for example, coming and presenting for screening. If they know there's a screening clinic and they've been having some funny palpitations or something, maybe they come. Do you have any sense of how many individuals had symptoms compatible with atrial fibrillation before they underwent screening?
No, we actually don't have that data, but we assume it to be extremely low because we specifically not invited a patient who was coming to be seen at the ER for screening. So, but we can't tell you the exact percentage.
Well, listen, when you display your tables in your paper, which I encourage the reader to take some time to read, because it really does paint a different picture of atrial fibrillation than we see in my institute in North America, for example. You nicely line itemize all the characteristics of the patients in whom you did detect atrial fibrillation. So why don't you paint a picture for the listener about the types of patients, these younger patients who turned up with atrial fibrillation after a very simple single time point screening. Who were they? What were their conditions? Why did they have atrial fibrillation?
Sure, thanks, Dr. Healey. So the participants that did return atrial fibrillation, there was 13. Of those, it was approximately half male, half female. They were surprisingly of a lower BMI than we would expect in a Western population for having atrial fibrillation. Albeit it has been suggested in the literature that perhaps the BMI cutoff of 25 perhaps doesn't necessarily relate to that of this type of community. We also noted that of the participants that were able to have the echocardiogram performed, that there were valvular disease noted for a lot of them. However, due to the limitations of resources in the area with regard to qualified sonographers, the echocardiograms themselves were more a visual assessment rather than quantitative. So based on that qualitative assessment, it was difficult to discern whether it was rheumatic in mechanism or whether these were valvular degenerative changes. However, certainly the presence of valvular disease was a factor for a number of these patients. The overall gist of the patients were that of the younger patients, certainly valvular heart disease was likely to be the primary issue, whereas perhaps for some of the older patients, it may be that more risk factors were things that needed to be looked at. Certainly, hypertension was the highest prevalent known risk factor for atrial fibrillation in the cohort, and certainly this is the kind of thing that can be potentially looked at for modification in a cost-effective way in a low-resource community, perhaps more so maybe than pharmacological intervention that would be more expensive.
You bet. I mean, it is quite impressive the different prevalence of different conditions in this younger AF cohort. Blood pressure, did you get a sense of control among the cases, among the controls, how well blood pressure was controlled?
The condition that a lot of the people screen with high blood pressure reading during the screening itself were unaware of their condition. So they weren't actually on treatment. So there will be difficult for, I think, this area with sometimes pretty low health literacy, and also the affordability of a blood pressure monitor will be difficult for them. And so we would have zero sort of minimal understanding of how they look after their hypertension. But if you look at some of the other papers published from inpatient data on stroke patients, there will be a significant number of patients with hypertension that were malignant, in the malignant range. So I suspect that the overall control of this risk factor is suboptimal in this region.
Yeah, so lots of opportunity for public health strategies to address this, and in some ways, these are resource limited environments, but on one hand, we have many interventions that potentially could be deployed at a relatively low cost. Case in point, your screening intervention. That's a fairly inexpensive way to screen for atrial fibrillation. Diuretics and beta blockers cost very little in the grand scheme of medications. And so, I think your study is beautifully highlighting how in areas of the world, in low income and low middle income countries, atrial fibrillation, there's great opportunity to improve patient outcomes, patient experience. And it doesn't involve, cath labs and expensive diagnostic testing necessarily. It's getting right to the problems that afflict this community. And as I see it from my own work and reading your work and others, simple things like rheumatic heart disease, hypertension, these are big players in this group of individuals with atrial fibrillation. And let's be honest, when individuals are getting atrial fibrillation in their 40s and 50s, that is a long time to live with this condition, and a lot of morbidity that we can hopefully improve. On the risk factor, I mean, in some cases, you just didn't have enough cases for statistical significance, but all the trends were in favor. Things like diabetes, hypertension, all were more represented among patients in whom you detected atrial fibrillation. Tell me about the body mass index, though. That tended to go the other way. Patients with atrial fibrillation tended to have a lower body mass index. So was this rheumatic heart disease? Was this some other infectious etiologies, or what was this? Or was this just play of statistical chance, perhaps?
Yeah, I think that's an interesting point that you raise about the lower BMI. I think it may just be that in that demographic, a lower BMI is the normal for that community, whereas perhaps in Western populations, the BMI then becomes larger, and then that becomes one of the factors in the substrate formation for atrial fibrillation itself. It may be that the patients that are getting atrial fibrillation are getting it for other reasons. So it could be valvular heart disease from rheumatic that may not relate as much to their BMI, but certainly for those with longer with more atrial fibrillation risk factors, maybe that might be the issue there. Certainly the diabetes, as you mentioned, is also something that's an issue for the community there, with making sure that they're aware that diabetes is an issue and a risk factor for atrial fibrillation. And certainly, I think the having screening as we've performed here raises knowledge within the community that the risk factors such as BMI and things are things that can be modified and controlled to reduce the risk of atrial fibrillation in the community in the future. The BMI specifically, perhaps, as you said, trends in the opposite direction within our study than what we would expect for a Western community, but it may just be that that's because of the demographic that we're sampling in a sub-Saharan African population.
Can I just add to this? We are in a more regional area of Ethiopia, but if we were to do the same screening in the capital, in Addis Ababa, in one of the more teaching larger hospital, it may well be slightly different, because in the more affluent portion of the community, there is a description of epidemiological transition where the living standards are higher, and there will be a higher prevalence of obesity and related metabolic syndrome sort of risk factors that may contribute to their AFib. So we are looking forward to perhaps getting some other data from different regions. So that will be a nice comparison to see there will be a degree of difference, I believe.
No, that's an excellent point, Dr. Lau. The differences we see here between North American and Western European cohorts are striking. Some of that are economic determinants, plain and simple. Some of those are cultural determinants, and some of those are, the differences in prevalent medical conditions that go along with the first two issues. Now, in terms of cultural determinants, you just display data showing very low rates of alcohol intake, for example, and that's, I guess, to be expected given the differences of the population you study here. In many Western samples, alcohol is an important population attributable cause for AF incidence, as is smoking. So maybe you could talk for a few minutes on these type of risk factors, so smoking and alcohol use in your cohort, and how you think that is important.
Yeah, look, smoking is a risk factor that we don't study all that well, as well in developed nations. One of the risk factors that we talk about, but more in the AF risk factor space, we will encourage people to stop smoking. The strength of the literature is weaker as compared to other established risk factors. In our screened population, both smoking and alcohol use were quite low. And I'm not sure whether it is in relation to the affordability of this screened cohort, and whether it may be different, again, if you were to go to a more affluent part of the society, then it would be with additional income more likely to be used more frequently. So based on what we screen and what we see, the contribution of these risk factors to the development of the AF is possibly low. However, we only did a single time point 30-second screen. There will be AF that we missed as part of this, and whether if you have repeated screening or longer duration, you may pick up a higher proportion of alcohol use. I don't know.
Yeah, no, I think it's very good, and again, your case report forms, your data are very specific to the area you study, right? You talk about cat consumption, not just cigarettes. And of course, when one gets into South Asia, you're talking about beaties and other things. So it is very important when one does research in these areas to be tuned in and have local stakeholders and really do this well. And I think, you've done a very good job. I think it's a great series that Heart Rhythm O2 is putting on in terms of atrial fibrillation across the world. I'd like to thank you both for joining us and showing us the face of atrial fibrillation in Ethiopia. Great potential, I think, there for screening to improve outcomes. And I would encourage all of the listeners here today to spend some time and look at the paper. It's well done. And again, congratulations to both of you and to your partners for this nice work. Thank you.
Thank you.
Thank you.
Thank you very much, folks, for joining us. It's time to conclude, and I would like to thank Dr. Healey, as well as Dr. Lau and Brad Pitman for the insightful conversations. Data creates awareness, leading to active screening and public health campaigns. So let's hope that there's a lot more good needs to be done, and we connect with our rest of the world, EP community and cardiology community. Hope you enjoyed this interview. Thank you.